We're going to be focusing on contemporary issues in radiotherapy for prostate cancer. It's my privilege to be co-moderating this session with my colleague and good friend Mark Pagoda. My name is Michael Zalewski from New York, and we have a very interesting series of talks, some debates, but raising some very important issues in urologic radiotherapy. And while we're going to try to keep on time, hopefully we'll have some chance maybe at the end to ask questions to the panel. The first talks will be focusing a kind of debate on the role of stereotactic ablative radiotherapy and hypo-fractionated regimens, which could be called a new standard of care for low and intermediate risk prostate cancer. The pro part of this debate will be given by Zvi Symon, and my pleasure to call upon you, Zvi.
Thank you for the invitation. I think in the program it says instead of stereotactic ablative radiotherapy, a new standard of care, it says a new standard of CARD, and it also says regiments instead of regimens. So I think that may be a sign of kind of competition between urologists and radiation oncologists. It's like a poker game, who best treats prostate cancer. Maybe it's a battlefield. But I think the fact that we've been invited as radiation oncology to this primary urology meeting shows that we can talk about this sanely. And I'd just like to disclose that I was a fellow of my opponent in this debate at the University of Michigan in 1999, Howard Sandler. So fractionation, for some people that may know what it's all about, it's really all about a ram's scrotum. So it's connected somehow to urology. So Coutard in France tried to sterilize a ram using a large single fraction of radiation, and he burnt the skin of the scrotum. And after further experimentation, he found that if you divide it up into smaller fractions, sterilization, but without burning the skin. So to put it in the context of prostate cancer, I'm giving an example of a few regimens of what we define by standard fractionation, which would be, for example, 2 gray a day to a total dose of 78 gray, which would be 39 fractions delivered 5 days a week. And what would be a typical moderate hypofractionated regimen, which we will discuss briefly today, 2.5 gray a day to 70 gray, 28 fractions, and then something that perhaps works slightly differently biologically and has a more ablative effect, and that is extreme hypofractionation, otherwise known as SABR or SBRT, and some of the surgeons like to call it radiosurgery. So this is based on mathematical modeling. We don't have time to go really into this. I will briefly say that this mathematical model talks about sensitivity of cells to ionizing radiation, and it's all about the sensitivity. So the alpha-beta parameter is indication of the fractionation sensitivity of a particular cell type. Typically, it's high for most tumors, about 10, but for prostate cancer, it has been generally conceived to be low and calculated, and it's about 1.5. So what does this really mean? It means that at a very low dose of radiation per fraction, you have very effective repair of the sublethal radiation damage, and therefore a high sensitivity to changes in fractionation. A slow proliferation time of prostate cancer cells reflected in the low alpha-beta ratio is actually lower than late responding normal tissue structures surrounding the tumor, for example, the rectum and the bladder. Thus, when we use large fraction sizes, this may increase the tumor cell killing effect while biologically protecting the surrounding late normal responding tissues. So therefore, why hypofractionate? So in fact, there may be an improved therapeutic ratio by increasing the fraction size. So we'll increase killing of the prostate cancer cells, and we will reduce the damage to the normal organs. We'll discuss briefly whether outcomes are comparable, and obviously this may result in reduced overall treatment times and may be economically more efficient, and it also reduces patient stress. So very briefly, I will just go through some of the moderate hypofractionation studies. There are over 15 studies, and 5 of them were randomized. To get to the bottom line, if you look at all these studies together, the biochemical freedom from failure survivor seems to favor the hypofractionated arm, and it was about 73% versus 66% for standard fractionation. And the toxicity seems comparable. So the NCCN has briefly summarized this and has stated that moderately hypofractionated image-guided IMRT regimens over 4 to 6 weeks have been tested. They report similar efficacy and toxicity to conventionally fractionated radiation and can be considered an alternative when clinically indicated. Briefly, in our own experience, we moved from treating in 2 Gray fractions to a very gentle 2.3 Gray fractions in 2009, presented some of our data at Astro, and currently, instead of 42 fractions, we are treating with 32 fractions of 2.3 Gray. We've treated over 400 patients, and we have comparable quality of life outcomes and excellent biochemical control. Let's talk about something perhaps more exciting, and that is, let's go extreme, let's go robotic. Let's talk about 5 powerful fractions of stereotactic radiotherapy or radiosurgery. So this was the first platform, a cyberknife, which is a linac on a robotic arm, and on the left is the older version of this, and on the right is a more souped-up modern version of the cyberknife. Katz published an update of their series on disease control and quality of life at 6 years. They were using 5 fractions only of 7.25 Gray, and they did have a lower fractionation scheme, slightly lower, of 35 Gray. And what one can see on the left is the biochemical control for the low, intermediate, and high-risk groups, which is excellent, and also the epic quality of life outcomes for bowel, urinary, and sexual outcomes that are extremely good. To summarize most of the data from these trials, there have been over 1,100 patients on phase 2 clinical trials of SBRT from 8 institutions. The median dose is 36.25 Gray, which is biologically equivalent to maybe 80 or 90 Gray, depending on exactly how you define the alpha-beta ratio in standard fractionation. And the 5-year biochemical relapse-free survival was 93%. For all patients. 135 patients have at least 5 years follow-up, and the control was extremely good for low and intermediate risk patients. So we have currently, there are a number of institutions, including Dr. Zalewski's institution, including another hospital in Israel, Beilinson, that also has a trial looking at this. This is actually transferring the technology from the cyberknife robotic arm to the modern LINAC accelerators with their image-guided platforms and 6D robotic couches and other technologies that can improve tracking the prostate. This is what we are doing at Sheba as part of a European trial with Raymond Mirabel This is the phase 2 study randomizing patients to 7.25 gray fractions, 5 fractions only. The randomization looks at how to schedule these fractions, whether to deliver treatment on alternative days and finish within 9 days, or whether to treat once a week. So this is done using the BrainLab ExactTrack system, which allows tracking of the fiducial markers intra-fraction. Treatment is extremely short compared to CyberKnife. It takes 4 minutes to treat a patient with a volumetric arc, and one can determine that there is no intraprostatic movement, intrafraction movement. MRI and CT are fused for treatment planning. A rectal balloon is used to distance the rectum away from the prostate, and there is an attempt to do a 10% central urethral sparing. Up to now, 10 patients have been treated on this protocol quite uneventfully. So to summarize and to conclude, the NCCN states that extremely hypo-fractionated image-guided regimens are emerging treatment modality with single institutional and pooled reports of similar efficacy to conventional fractionation. They may be considered as a cautious alternative in the clinic with appropriate technology, physics, and clinical expertise. We have been slightly more conservative at Sheba, and we're doing this only in the context of a clinical trial at the moment. Thank you very much.
Thank you, Dr. Symon, and now Dr. Sandler, who is, was at University of Michigan and currently the chair at Cedars-Sinai, will be taking the Kahn approach for stereotactic body radiotherapy in prostate cancer and give us his thoughts.
It sounds like, thank you, Michael, for the introduction. Taking the Kahn approach makes it sound as if I'm trying to talk you into something, and maybe that is what I'm going to try to do. But I prefer to think of it as maybe a more cautious approach to this new modality. I just wanted to mention that most patients, I think, who are treated with these extreme hypofractionated approaches are those with lower risk prostate cancer, those who we feel comfortable treating with very, very tight margins because we're not concerned so much about the risk of extra prostatic extension. After all, you can't do extreme dose treatment and use large volumes at the same time. So to use these approaches, one has to be willing to treat very tight target volumes. And with a lot of extracapsular extension, you do risk, I think, undertreating disease on the edge. Now for Gleason 6 prostate cancer, a disease that honestly I don't see that much very more in Cedars-Sinai. They're either not being discovered or being surveilled or getting robotic surgery. But perhaps the correct dose of radiation therapy is 0 gray for these patients, and they may not need any treatment whatsoever. So SBRT has been around for a while. As Dr. Symon nicely reviewed, there's a number of single institution reports for the use of extreme hypofractionation. And last year in 2013, the American Society for Therapeutic Radiology and Oncology, on their website, under their section where they talk about billing issues, issued this statement, which has actually been relatively influential, about the use of SBRT in the management of prostate cancer. And I highlighted their concluding statement in yellow at the bottom, and it's, quote, "It's Astro's opinion that data supporting the use of SBRT for prostate cancer have matured to a point where SBRT could be considered an appropriate alternative for select patients with low to intermediate risk disease. I'm not exactly sure what they meant by this. I honestly don't know how Astro came up with this model policy statement. Their methodology for endorsing SBRT was not disclosed. But low to intermediate, I'm not sure exactly what that means. Is that just low, or is that, I mean, if they meant intermediate, they would have said low and intermediate disease, but they said low to intermediate. So when I read it, as I'm not a lawyer, but to me it makes it sound as if only low risk disease would be included by this relatively soft statement of support. So at my hospital, I'm not anti-SBRT, and we've participated in a clinical trial that was developed by another Michigan colleague of mine, Dan Hamstra, looking at this in a phase 2 multi-institutional setting with very tight margins, using Calypso as intra-treatment localization technique. I'm not going to get into the radiation therapy technology, but suffice it to say that it's important that this be done with a fair amount of care. Now, I do have a big role in the RTOG, and I just have a couple of slides about this clinical trial that was led by Himu Luka from Hamilton, Ontario, a randomized phase 2 trial of hypo-fractionated radiation therapy for low-risk prostate cancer. And this was the design for T1 and T2 tumors, low-risk tumors. They got the, quote, CyberKnife-style regimen at the top in yellow, or they got what I like to call the Jack Fowler regimen of 51.6 gray over 12 fractions. Zvi nicely showed a figure from a Jack Fowler radiobiology paper, and this regimen was developed directly from the Fowler alpha-beta calculations. This study accrued well in the US at a number of centers, and over 250 patients have accrued, and the study is closed. And in 2015, we'll learn whether there has been a significant alteration in quality of life from what I consider to be potentially a more valuable experience, a prospective randomized trial from a number of centers versus a very carefully selected single institution experience. So as we know that hypofractionation is a higher dose per fraction, lower total dose. And for many of the studies that have been done, the hope is that it's effective for tumor control and acute and late toxicity. Now, fortunately, there's been a lot of work done in this area. So here's some of it that I'll just highlight. The CHIP trial from the UK and Canada, but mostly the UK, has completed accrual with more than 3,000 patients in a randomized trial looking at standard fractionation versus 3 gray fractions to 60 gray or 3 gray fractions to 57 gray. It excluded T3 and Gleason 8, but otherwise pretty much anyone else was eligible. According to someone who I know who's on the steering committee for this study, we should have data in 2015 from this trial. And obviously, if a large trial like this shows that the hypofractionated regimen is equally effective, then I think we'd be certainly validated in using this mild hypofractionation. The hard part will be is, what if it shows that it's let's say, slightly better biochemical control and slightly more toxicity? How do you weigh extra toxicity with extra biochemical control? I think that'll be a challenge. In Canada, there was a trial done of 78 gray in standard fractionation versus 60 gray in 3 gray fractions. This one was done with a non-inferiority design. So even though the alpha-beta ratio is considered potentially more effective, what we what we find is that people are designing trials to look for non-inferiority. Although in this trial from Sweden, 600 patients still accruing 6.1 gray regimen in 7 times 7 fractions versus standard fractionation. So I think all 3 of these trials will generate higher quality, higher level of evidence, and will allow us to make better informed decisions in the future. Now, one of the things we should be concerned about is that GU toxicity, and most of these trials do not spare the urethra, GU toxicity can be a late event. And if you look at the x-axis here, you can see that this GU toxicity curve from the SEER database in the US continues to increase out to 10 years. And so trials with 1 year or 2 years of follow-up may not capture the full extent of GU morbidity. This study was presented at ASTRO last year by James Yu, looking at a US Medicare database. It was published in JCO in 2014. And this looks at observed toxicity that they captured in an administrative database. It's not patient-reported quality of life, but this is related to procedures or other indirect evidence of toxicity. And you can see that if you look to the left under the GU section, the asterisks indicate higher toxicity when SBRT was used compared to when IMRT was used. Is it worth it? Is it worth subjecting your patients to a potential for higher risk of toxicity without evidence of extra benefit with SBRT? Anthony D'Amico, who wrote the editorial that accompanied the JCO article, said that there were some issues. You didn't know what the baseline factors were. He didn't know anything about radiation quality. Maybe the toxicity was associated with people who were novices at SBRT. And his quote is, when treating men with prostate cancer, it's acceptable to recommend a more convenient, it's a question, is it acceptable to recommend a more convenient treatment that takes less time and is less expensive, despite the possibility of increased toxicity? I don't think so, is what D'Amico says. Accelerated RT regimens utilizing CyberKnife or SBRT should only be performed in the setting of well-designed clinical trials. Is it more convenient? Does it really save time? And perhaps a 40 fraction regimen at 15 minutes a fraction may take 600 minutes. A 5 fraction regimen that takes longer, we clock 30 minutes for our patients, takes 150 minutes. So you save 450 minutes or about 8 hours. And in a 65-year-old with a 20-year life expectancy who might live another 182,000 years, yes, saving 8 hours does save some time. It saves 0.004% of the remainder of this guy's life. Is that savings really worth the uncertain added risk of toxicity? So in summary, SBRT, according to at least one important study, has more urinary toxicity than IMRT. It does take less time. Randomized trials are underway, and my recommendation is to treat with SBRT only on study until we have higher quality data. Thank you.